Okay, so now we're recording. So welcome everybody. Welcome to the training tonight. So the training tonight is take-home naloxone training for community pharmacies in City and Hackney. My name's Graham Parsons. I'm Chief Pharmacist at Turning Point. If I could just introduce Jenny. Jenny, do you just want to introduce yourself, please?
Hi there. Good evening, everybody. My name's Jenny Scott. I'm a senior lecturer at the University of Bath at the Department of Pharmacy and Pharmacology, and my research is all around harm reduction and addiction treatment, particularly from the pharmacy setting. And I also work as a pharmacist prescriber with Turning Point in their service in Wiltshire. So it's nice to be able to share some practical outcomes from the research that we've done.
Lovely, thank you, Jenny. So I'm just going to share the screen now. Now, Jenny will be taking you through the training, but I will be the master of the slides, as it were. So Jenny will be instructing me because I think I've got the computer set up so you can hear the videos, which we've had problems with in the past. So Jenny, over to you.
Thank you, Graham. Thank you. Oh, well, as I said, good evening, everybody. Thank you very much for giving up some of your evening to attend. We're going to take you through the training in quite quick time, definitely no more than an hour to go through everything, but we will cover the basics and we will make sure that you feel by the end of it able to supply naloxone. There's a few important points. Importantly, our intervention is aimed at every member of the pharmacy team. So this training is also aimed at every member of the pharmacy team. So it's not limited to pharmacists. As Graham said at the start, it comes from some research I did last year and the year before, and this is us translating that to something useful and something practical. And the current pandemic has sort of expedited that. It was always the plan, but has allowed us to take this forward quickly because Public Health England instructed drug treatment providers to look at ways to maximise naloxone supply during the pandemic, and we'll come back to that in a little while. For anyone who's working through this, particularly afterwards on their own, there are links in the presentation. Blue links are optional. They tell you a bit more if you want to know more. And the red links, which Graham will do the clicking on in a little while, they're the ones that we would like people to look at for definite, because they've got key information that we want to get across. So thank you, Graham. Can we have the next one? Can you hear me, Graham?
Yep, I have forwarded it, Jenny.
Thank you. There we go. Right. Okay. So what is naloxone? Well, naloxone is a medication that reverses the effects of opioid medication, opioid analgesics like heroin and methadone. So in the event of an overdose, it comes along and it knocks that drug out of where it's having an effect, the receptor where it's having an effect, and it reverses those effects very quickly. So it's very quick acting, and it's also quite short acting. It's available in the UK in two forms, as an injection and as a nasal spray. And this evening, we're training you to supply the injection. We'll mention the nasal spray briefly later on, but this is about the injection, and we'll show you the contents of the container and go through how to use it. It's described as an opioid antagonist for those who like a bit of pharmacology, which basically describes its effect on the opiate system. It blocks opioids working. It's very much about first aid, okay? And we want to really make that emphasis on that point, that naloxone in the community, distributed in the community, is about having a first aid medicine to hand when it's needed. Graham's going to just click on this short film. It takes about 3 minutes, but it's really key and it's showing you how naloxone works. The only point to make is it is American, so obviously it's got Americanisms in it, but it's very applicable to UK.
Okay, here we go then, Jenny.
Thanks,
Hopefully people will be able to hear the sound on this.
People are dying every day from opioid overdose.
You hear that?
Parents and children, neighbors. But naloxone can help. Naloxone is a safe and effective rescue medication that reverses the effects of opioids and saves lives. To understand how naloxone can stop and reverse the effects of an opioid overdose, it's helpful to see how opioids work in the body. Opioids are agonists. This means they bind to and activate specific receptors in the body, including the brain, brainstem, and spinal cord. When these receptors are activated, people experience the effects produced by opioids, such as pain relief, euphoria, calmness, relaxation, and slowed breathing. Taking too many opioids causes so many receptors to fill and activate that breathing may become dangerously slow and even stop. This is how an opioid overdose happens, and this is where naloxone can help. Naloxone has a strong affinity to opioid receptors, more so than most prescription opioids and heroin. But unlike opioids, naloxone is an antagonist. This means it attaches to opioid receptors without activating them. So when naloxone is administered during an overdose, it knocks the opioids responsible out of the way and allows breathing to normalize. Naloxone can be administered through an injection or a nasal spray. It usually starts working within a few minutes and lasts from 30 to 90 minutes. While one dose of naloxone can reverse an overdose, sometimes multiple doses are needed, especially in cases involving extremely potent opioids like fentanyl, or opioids that stay in the body longer than naloxone. Naloxone is very safe in single or multiple doses. It may produce withdrawal symptoms in people with opioid dependence, but it has no abuse potential and cannot cause an overdose. It's important to remember that naloxone is opioid specific. It has no effect on an overdose caused solely by non-opioid substances like benzodiazepines or alcohol. At the same time, people shouldn't be afraid to use naloxone when the cause of an overdose is unknown. If opioids were not involved in an overdose, it won't cause any harm. If opioids were involved, naloxone can save a life.
Great, thank you, Graham. Okay, hopefully you can all hear me again. So it's important to reassure you that the law in the UK allows naloxone to be supplied without prescription, and that law applies to certain groups of people. The terminology is people lawfully engaged in drug treatment, and that confirms that's been confirmed to and does include pharmacy teams who provide treatment to people with drug problems. So that includes opioid substitution therapy like methadone or buprenorphine, or people who have needle and syringe provision through needle exchange schemes, similar programs. So pharmacy teams very much can provide naloxone. Now, in terms of who you can give it to, well, the law doesn't actually specify, and that's quite a good thing in many ways, because it allows you to sort of judge each situation as it presents. But there is guidance. So guidance suggests that you can supply it to people who use drugs themselves. That's the obvious recipients, I guess, but also to their family members to keep at home, or carry it with them, to their friends, to people who care for them, to people who look after them where they live, so hostel staff, outreach workers, etc. So as I say, that's not a legal restriction on those groups, it's just recommended that they are considered. But you may well have a specific situation where another person you think has a need, and that judgment is left to you, so that's okay. The key thing is it's supplied and administered for the purpose of saving a life, and anyone can administer naloxone. It's same legislation as EpiPens, so anyone could give it if they have the potential to save a life at that time point. Okay, Graham, next one, please. Thank you. So that's the legal bit. That's how it works in the legal bit. But why are we asking you to do it, and why is it so important? The bottom line is sadly that drug-related deaths in the UK have been escalating at a really, really concerning rate. We've really had really high figures. In 2018, they were the highest since records began. We just literally 2 weeks ago had the figures for 2019 published. They've come down by about 100 people, but really not any significant decline. So we've got these really high numbers of deaths where opioids are on the death certificate, and that's heroin or other opioid medications as well. Heroin being by far the most common one. And as I said, it's the highest figure since records began, and it's 5 times higher. So it's huge, the escalation. These deaths are largely preventable, and we mustn't forget that they're people's family, people's brothers, sisters, children, parents, etc. So each and every death is absolutely tragic. Scotland has even more concerning figures than England in terms of per head of population. So it's really something that needs lots of different approaches, a multi-pronged approach. I'm not saying that the answer is just to give out more naloxone, but as I mentioned, as a first aid medication, it's going to potentially make the difference between an overdose being fatal or not being fatal. It's not going to stop the overdose, but it's going to make a difference to the outcome of that overdose. And the really key thing, the key reason why naloxone has been made available on a take-home basis and why the legislation was introduced is that we know that the majority of overdoses actually happen with another person nearby. So either in the same room or in a different room in the same building. And therefore there is potential, if naloxone is on the premises, if the person who witnesses or is nearby to that overdose has it to hand, that they can give it quickly, and the quicker it's given, the more likely it is to work. It's much more effective if it's administered shortly after that person stops breathing, rather than after a period of time that's longer, and the potential to prevent the damage from lack of oxygen to the brain is obviously much greater if that brain is not deprived of oxygen for a long period of time. So absolutely getting it into the hands of people likely to witness an overdose is critical to saving lives, and that's really where this all comes in, and where pharmacy is so important, as I'll explain in a minute or two. If you're interested in why drug-related deaths are increasing, There's a link there to a report from the Advisory Council on Misuse of Drugs. They advise the government on drug-related issues, and they did a very detailed report on all the different factors that are contributing to drug-related deaths. So that's all in there, should you wish to read it. Okay, Graham, next one. Right, and this is what you really, I'm sure, want to understand and want to know, and I hopefully will be able to convince you of your importance to this. It's absolutely central what pharmacy can do. Some of this I know you've heard before, and sometimes it's hard to say this top one without it sounding like you know, everybody wants to say it, and it sounds a bit tired, but I can't overemphasize how important it is how accessible pharmacies are. You know, drug services are in towns, in bigger towns, in areas, cities such as, you know, obviously for yourselves, but you know, they're not easily spread across the population, and people have to travel to access them. They're not open at weekends, they're not open evenings. Pharmacies are much more accessible. The majority of the population live in walking distance of one. I think the actual report was 90% of the population are within 20-minute walk of a pharmacy. And obviously in a big city like in London, people are going to be even closer to pharmacies. So they're absolutely critical because they're so accessible. But there's more to it than just accessibility. You are all experienced in providing services to people who use drugs. Therefore, you're used to talking to people, connecting with them, interacting with them. And the other side of that is people who use drugs are used to you. They're used to coming to pharmacies. They value pharmacy services. They rely on pharmacy services, and they know that you look out for them and that you have an interest in their health. And therefore, that relationship is so important in provision of naloxone. I mentioned opening hours already, so that's obviously critical. And then, of course, the other very important point here is for those of you that provide needle and syringe provision through needle exchanges, you will be seeing people who do not want to come anywhere near a drug service. People, by the time they come through our door in a drug service, they've reached a sort of certain point and have a certain, I suppose, relationship with their drug use. They tend to be sick of it. They tend to want change, and they seek change, and that's why they come to us. But you see the people upstream to that, the people earlier on in their drug use who perhaps are not that interested in change. They can be hard to engage. They certainly don't want to come anywhere near us in a drug service. But we also know they are one of the groups most at risk of overdose. So you're really the only healthcare service that connects with them on any regular basis anyway, or through talking about their addiction either, you know, and knowing that they have an addiction. They may well see their GP, but may not necessarily tell them that they use drugs. And then the point I made at the start, just to emphasise, is that Public Health England have emphasised the importance of naloxone supply at the moment. During COVID, you will know this from your practice, there's been more takeaway dosing of opiate substitution therapy, so more takeaway methadone, larger volumes of methadone. We also know drug supply networks have been disrupted, albeit not long term, but certainly at the start of the last lockdown, and no doubt at the lockdown we're just about to go into, and that causes people to take more risks. It causes people to try and stockpile drugs, to buy drugs from people they don't know, and therefore they you know, they're not sure about they're never sure about the quality, but it's a particular risk about quality and where that person might get those drugs from, and they may be very different from what they're used to and potentially cut with other things. So the pandemic has really emphasised the importance of trying to respond to what we fear might be increased overdoses, and trying to prevent the death statistics going even higher at this particular time. Okay, Graham? Right. So hopefully I've convinced you. Hopefully you're now thinking, yep, you've sold it to me. I completely understand pharmacy is critical in this. You know, I should say at this point that, like Graham, I have worked in community pharmacy for quite a number of years as well. So I do get the context that you're in. Right. So a bit more about what we're asking you to do and a bit more about the practicalities. So this, hopefully you can see it as Prenoxad. You can see it on the screen as well. This is what we're asking you to supply. It's a kit. It's got inside it, as you can see on the screen, it's got a pre-filled vial with a lock on the lure lock on the end where you can attach a needle. It's not a completely pre-filled syringe like an EpiPen. It is separate. People have to connect the needle, and you've also got instructions in there, and we'll go through this with a video clip as well. But there's instructions in there for the person that you can say to them, you know, take out the instructions and it will tell you how to assemble it and how to administer it as well. So, you know, it is all in there with the medication. So Graham's just going to click on this blue link here that shows you how to assemble it and tells you a bit more detail.
To use Prenoxad injection, remove the wrapper using the tear strip. Twist the outer plastic box to break the seals and open. Take out the Prenoxad injection syringe and one of the blue needle packets. 2 are supplied in case one is damaged or becomes contaminated, for example by being dropped on the floor. Peel back the backing paper from the needle packet and remove the needle, keeping it in its protective sheath. Unscrew the clear plastic top from the syringe. With the needle still in its sheath, screw the blue fitting onto the syringe. Holding the needle on the syringe with your thumbnail, gently twist the sheath and remove it. Twisting the needle sheath instead of pulling it avoids needle stick injury. Holding the syringe like a pen or dart, insert the needle at right angles into the outer thigh or upper arm muscle, through clothing if necessary, and inject to the first black line to give a 0.4 milliliter dose. Withdraw the needle and put the syringe with the needle still attached back into the cradle of the Prenoxad injection case. If you give another dose, insert the syringe again near or around the same site and inject to the next black line. After using Prenoxad injection, keep the syringe in the box and hand it to the ambulance crew so that they know it's been administered. Watch the main film so you'll know what to do if you suspect someone is experiencing an opioid or opioid-related overdose.
Thank you, Graham. Right. I'm just going to talk for a little while about how to offer naloxone to people in the pharmacy setting, because this is really critical to the success of people taking it. The research that I did, it started out because we noticed that in some areas people were supplying lots of pharmacy naloxone, or in some particular pharmacies rather, and in other pharmacies, even though they'd had similar training or the same training, people were commissioned, but they weren't offering it. So we wanted to try and understand what makes it work. What is it that the people who are supplying naloxone regularly are doing to get it in the hands of people who potentially might need it. So I'm going to take a few minutes to sort of give you the headlines on what we learned and to go over some of that. The first thing, and it may seem obvious, but it's absolutely critical, is to be proactive. So don't wait for people to come in and say, can I have a naloxone? Because they won't. Certainly not at first. They might once they they know you supply it once they've had it before, but they certainly won't do it initially. And I've got to say that in the drug service, it's absolutely the same. You know, I can sit with an appointment with somebody, they don't mention it at all, and I always have naloxone on the desk, and I say to them at the end, do you need one of these? And they'll go, oh yeah, somebody overdosed last night in the hostel and I used mine. You know, and I don't understand how that can't be in someone's, you know, front of their mind, but it isn't. So be proactive. I've got a quote here from a pharmacist who was supplying, if I remember rightly, about 25 a month. So a busy, experienced supplier of naloxone. And he said to me, when I asked him, well, you know, how do you supply so much? What happens to make it successful? And he said it would be us offering it. If we slack off on that, then we notice naloxone supplies are less and less. So it's usually us, it's not the other way around. So absolutely be proactive, offer it to people. Next one, Graham. The second thing that absolutely works and really I think is critical in a pharmacy context is to link the offer to a related service such as needle exchange or methadone. So I call that hook. Obviously, you need to be able to identify people that might benefit from naloxone, and you're not just going to offer it to anyone and everyone. So the obvious thing is to link it with people who are already receiving a service that says, I use drugs or I have used drugs, potentially there's a risk there. And that makes the conversation easier to initiate, and it also makes the person more receptive to having that conversation because they know that they've already presented for a service that confirms that they are somebody who uses drugs. So linking it with that offer is really, really critical. Obviously in a drug service, you know, when we see people, again, people are here because of their addiction problems, so we can do that too. And then the third thing is keeping it brief. And one of the things we learned from this study looking at why do some people do well and some people don't was about the pharmacist's approach. And I say pharmacists because the people we spoke to were all pharmacists, and their approach to the supply. And the ones that were supplying more were ones who had themselves crafted the intervention down to a couple of minutes, 2 or 3 minutes max. And I think it's important to say that we also did work with people who use drugs themselves, and they absolutely echoed this, you know, that if people come in, particularly for needle exchange, it's usually the last thing they do before they're going to use drugs. They want to be quick. They might be experiencing withdrawals at that point. They don't want to sit down 20 minutes and go through something which is very detailed and takes a lot of time. And certainly the intervention as it was in one of the localities I studied was a sit down and work through several pages of information, and people didn't want to engage in that. They didn't want to go and sit in the consulting room and potentially wait for the pharmacist to be available and then go through something else that took maybe 20 minutes or so. So the people that were successful told us that they'd narrowed it down to 2 or 3 minutes, and it was quite akin to an over-the-counter medicine supply rather than emergency hormonal contraception, as an example. So a quote from one of those pharmacists, she said, we capture these patients as they walk in for needle exchange, when they're prepared to go and use drugs. So the last thing on their mind is to be having a conversation. She just went on to talk about narrowing it down to 2 or 3 minutes of the key points, so that people were willing to listen. Okay, thank you, Graham. And on that basis, when we were looking at the intervention, we decided that the important thing was to prioritise supply. So if people don't have naloxone in their hands, I know this is obvious, but you can't give it if you don't have it. So prioritise the giving of the supply over the giving of the information. The information leaflet, as I say, covers all the points, and there are also tear-off leaflets that come from the manufacturer that we can get to you that also cover the key points. It's incredibly safe, naloxone, so in terms of the risk of harm, there really isn't any risk of harm, and particularly when you think about the context that if it's not given and someone's not breathing, they're going to die. So in terms of sort of the balance of all these factors, when we thought about it, prioritising the supply came to the top as absolutely critical. And what we've certainly found in the drug service now, we've been supplying it for about 5 years, is that increasingly people are very used to naloxone now. You know, they've seen it used, they've used it themselves, or they're certainly familiar with it. And potentially, you know, in a resupply, if they know how to use it and they understand how to use it, it's going to be super quick, because it is really just checking that they're comfortable with how to use it, whether they have any questions or anything you can help them with. I think it's also critical, and obviously at the moment with COVID, it's actually going to be the case anyway, but that supply isn't contingent on sitting down in the consulting room. Again, the pharmacist we spoke to who supplied a lot said, I can be discreet without taking people in the consulting room. Not everybody will want to be in an enclosed space with you. A lot of our clients have got quite significant trauma and find that quite uncomfortable. They feel it draws attention to them, or they just don't have the time. So it's quite possible, as you will know from selling medicines over the counter, to be discreet, and not every medicine sale will be done in the consulting room. So, you know, obviously if someone wishes the consulting room and in times when it's available, we're not saying don't use it, we're saying don't make the supply contingent on being in the consulting room. I interviewed somebody and she said to me, oh, a few people have been interested in it, but when I tell them to go and sit in the private consulting room, they don't want to stay. So that's critical, that's not contingent. Something I would say that a couple of the pharmacists who supplied a lot of naloxone mentioned, and I'd be interested to hear if we've got people from Somerset and Wakefield who've tried this. It's something I certainly do in the clinic since it was mentioned, is to have it to hand when you offer it. So I now take peroxide and put it on my desk in the clinic, and apart from it, it sort of reminds me to ask people about it. Often people will raise the topic themselves if they know what it is, and they'll say, oh yeah, I need another one of those, thanks. It's just visible. So possibly think about having it in your hand as you offer it. People might not know the name naloxone, but they may recognise the box, or they may have heard about it and heard it's in a yellow box. And I just find it's quite a useful way to start the conversation. Have you got one of these? I often say, or do you need one of these? And if they don't know what it is, they'll say, what is it? And then you can open up that conversation. And if they do know what it is, I can say, have you used it before? Do you know how to give it? Okay, next one, Graham. Right, so useful phrases. Again, this comes from the pharmacist we interviewed. Do you have an naloxone kit, and showing the box, or as I say, my one is, have you got one of these? You might wish to give a bit more information or be a bit more persuasive. So things like overdose, deaths or soaring. So lots of people now carry naloxone in case they see someone overdose. It's free, it's easy to use, and I'd like to give you one to take away. That came from somebody in a pharmacy in Glasgow. And then after people agree to have a kit, I think the key points are there are 5 doses in the kit. You give each dose injected into the thigh 2 minutes apart. And if you give it in those separate doses, that avoids bringing people around in a bad withdrawal. And the reason we don't want them to come round in an acute withdrawal is that they're more likely to then go and use drugs again to deal with the withdrawal effects, and obviously the potential for overdose is then reignited, particularly because naloxone is quite short acting. And if they've got a mixture of drugs in the system, as very often is the case in overdose, so it won't just be heroin, it might be heroin, methadone, benzodiazepines, alcohol, all in the mix. You really don't want them topping up with further opiates. So ideally, the advice is give 5 doses. I maybe should say at this point, though, if people do give it all at once, it's not harmful in the clinical sense. It just, as I say, could cause that acute withdrawal. Okay, other bit of information that can be quite useful is there's a leaflet in the kit that explains how to use it. You need to attach the needle first. And as I say, if you have the tear off leaflet, you can also say, you know, this leaflet tells you how to use it in more detail. And then the third piece of information that is absolutely key is the message that when you give it, phone an ambulance. You know, as I said, this is a first aid response to an overdose situation. It's not the be all and end all or the only answer. So the advice is phone an ambulance and make sure that you stay with that person until the ambulance comes, and try and carry it with you. The other thing that has been identified in other research recently is that sometimes people take naloxone, but they leave it at home, or they leave it just you know, where they think they themselves will use drugs, or they don't want to carry it around with them. But actually, for obvious reasons, you need to have it with you, so that if the person themselves overdoses, it's in the pocket. Someone might search the pockets and find it, or if they witness an overdose, they've got it to hand to respond to that. Okay, Graham, next one, please. Right, it is important to say you develop your own style and your own approach. So I'm not telling you what to say. I'm just telling you what other people have told me they find helpful and what I found helpful myself. But you know, you will develop your own style, and I'm sure that will be absolutely great. We do have a couple of short films that we made in the lockdown at home. I made to give you a couple of examples, but as I say, they are not cast in stone. You can do your own thing, but I think Graham will maybe be able to play them to give some ideas.
Oh,
Hi.
I'll get one more pack.
Yeah, sure. Can I give you naloxone as well? A lot of people are dying of overdoses, and it reverses the effects, and a lot more people are able to carry them now. So we're asking people if they'll take one.
Okay. Yeah. What do I do with it?
It's got 5 doses in it. If you have to give it to somebody, screw the needle on, inject it into the thigh,
okay,
and then just give down to the first mark, wait a couple of minutes. If they don't respond, give them again. Don't respond, give it again, and you can keep doing that until they respond. You need to call an ambulance as well, okay?
Okay.
Make sure you always carry it on you. Okay.
All right. Cheers.
There you go. Thank you. Okay, the next one is somebody in a bit of a rush.
Hello. I'll get one more pack.
Yeah, sure. Can I give you naloxone as well?
In a bit of a rush.
Okay, well, take one with you. It's got a leaflet in there. There's a leaflet in the pack as well, tells you how to use it, okay? Any questions, ask us next time, right?
Yes.
Okay, so that illustrates the prioritising supply. Obviously, in an ideal world, you want to give a bit more advice, but he left with it rather than without it. And obviously, some of our clients, we don't know when we'll see them again or if we'll see them again. Okay, so next one, Graham. Right. Okay, so what about if people refuse? I think it's fair to say we're seeing a willingness to carry naloxone more than we used to. I think in the early days we got quite a lot of refusals. People were apprehensive. They thought if they got stopped and searched it was basically an admission to using drugs, and they would get in trouble. But we are finding more and more people willing to take it. But some people do refuse, and they do still refuse. And sometimes that's for good reason or valid reason, and sometimes it's not. But do keep offering it, and even offer it to the same person again when you see them again, depending obviously on the circumstances and if they give you any reason for refusal the first time. If they do refuse, ways you could close the conversation, things like, well, if you change your mind, you're welcome to come back another time. You could say things like Turning Point or whatever your service is going to be called locally. Turning Point can give it out too, and they have it as a nose spray for people that don't like needles, which is true. We give a nasal spray or the intramuscular, or something along the lines of, please think about it, overdose rates are very high and we're trying to stop people from dying. And you know, again, you'll get more experience. The more you do it, the more you'll feel confident to challenge. You know, or if you don't want to challenge, well, you offered. You know, at the end of the day, you've done a great job just by offering it. So it's about what feels right for you in the circumstance. Next one, Graham. We've got a little film of somebody refusing it. Really, just what we just said.
Hello. Hey, get a 1 ml pack.
Yeah, sure. Can I give you naloxone as well?
No, I don't need that. No.
Have you heard of it?
Yeah, I don't want that.
Okay, well, change your mind. Anytime you're welcome, we've got it in stock, okay?
Okay, cheers.
Thanks, Graham. Right, okay, so reasons people might refuse. Well, there might be a valid reason, like they don't need it. So, you know, they may take 1 ml insulin syringes for injecting drugs that are not opioids. So, for example, amphetamines. And as the little film at the start showed you, naloxone's not effective on drugs that are not opioids. So it wouldn't have any effect on amphetamines or benzodiazepines or the like. So they might themselves know it's not worth them having. But I think probably more commonly what we see is people who think they're not at risk. So smoking heroin is less of a risk than injecting, but they might still witness an overdose. And I think they don't always think like that. I know when I say to people, what if you see someone else go over? Sometimes they haven't thought that one through. They've just thought about themselves. Or they assume because it's a medication, we're only supplying it for them to have administered to themselves rather than it's got the potential to be used on others. And as I said earlier, if they combine drugs and alcohol, or CNS depressants and alcohol, the risks are greater, even if they're smoking heroin. We do also find people who are embarrassed. So sometimes as they get to know you, they'll reconsider. They might remember you were pleasant, you openly accepted that refusal. You're like, oh, that's fine. If you change your mind, we're here, we've got it, just ask. And they might actually think next time, actually, okay. Or something might happen that challenges the perception that they think they're not at risk. I do find sometimes people in treatment, when they come to treatment, they're so kind of desperate to change their situation. They don't want naloxone because they're adamant that, well, actually, now I've started treatment, I'm not going to use again. And, and fair enough, I think it's a line we've got to tread carefully, and we see how they go. And, if they don't stop using, we'll sort of gently offer it again at a future appointment. Sometimes people don't want to acknowledge the risks. That happens from time to time. They absolutely know they're at risk and they just don't even want to think about it because they know that it's a reality that could well happen. What I do tend to do in that situation is I'll say to people, or a phrase that is quite useful is, have you ever witnessed anyone overdose? And the majority of people who use heroin have witnessed someone else overdose. We know that from research by King's College in London. So sometimes the phrase, have you ever seen anyone overdose, can open up the well, you know, if you've seen it once, you might see it again. And you know, that can perhaps make them think or encourage them. I'm convinced some people take naloxone from me just to shut me up, to be honest. I go on about it so much, but I don't think that's a bad thing. And then I mentioned about fears of sort of being searched or you know, sort of labeling themselves as a drug user, but actually increasingly custody suites are supplying naloxone and police are carrying naloxone, so attitudes have changed in recent years. Okay, next one, Graham. So just to finish, key points. We'd like you to think about naloxone supply more akin to an over-the-counter sale than a detailed intervention like emergency hormonal contraception. It should be quick. Hook your offer into request for needle exchange or methadone can be really helpful because that person's already presented for addiction care and you're sort of adding an extra thing with that. Please, I would really strongly encourage you, if the majority of our attendees tonight are pharmacists, I would really encourage you to think about training your whole team, because the pharmacists that I've spoken to in research and the ones that are supplying the most in our other pilot sites, I know have engaged the whole team. And that's really critical because you must know that bottleneck feeling where, you know, you've got 20 things to do at the same time and nothing can move forward until you're available. And actually, supply that doesn't rely on the pharmacist can, of course, continue when you're busy. And in the drug services, we have absolutely everybody who has a client-facing role is trained. So all our drugs workers, all our healthcare assistants, all our nurses, all our doctors, obviously, pharmacists. You know, it's not just the clinical team. We've got anybody that meets a patient can give it. So, you know, that model can work elsewhere as well. It works really well for us. So absolutely do think about training your whole team and encouraging them to complete this, because it really seems to make a difference. And obviously we'll get more information once we've done the evaluation on that, but we think anecdotally at the moment it does make a big difference. And the pharmacists I spoke to certainly said that was really critical for them. We've got dummy kits. You saw me waving one around just now. If you want a dummy kit, we can get one to you. I find them really useful to demonstrate to clients, you know, what's in it and how it works. So, you know, do let us know. Similarly, the tear-off leaflets, we can get those to you as well. Any comments or questions? Graham and I are both happy to receive them. We've got our email addresses there. And I think, as Graham said, the next thing we'd perhaps like to do is invite comments or questions, and also if we've got anybody on the call from Somerset or Wakefield who's happy to share their experiences, that would probably be really valuable as well.
Thanks, Jenny. So yeah, the first thing I think it'd be useful to really share the experiences of the other services. So we'll try and do this in a structured manner. So if anybody's from Wakefield or Somerset and would like to share their experiences, please put your hand up and I will invite you in. Okay, Sally.
Hiya. Hello. Yeah, we've been quite successful in Burnham-on-Sea and I think Yeovil Henford, just sort of catching people when they come in for needle exchange, really, and methadone, and definitely getting the whole team trained as well is really important, because I can't always be there to do it, so that's really helped as well.
Sally, in getting the whole team trained, how did you approach that?
So they've I think Yvonne sent a link out and they sort of did some training online and then got accredited that way. But I've had a change in team, so I've still got some people that need to do it in my branch, but I think they did it in Yeovil.
Okay, that's great. So we're going to talk about I mean, obviously, this training is going to be online. It's going to be available for YouTube, and you know, you can work your way through that. Our experience is that people who have actually attended this training have been the higher performers as well. So we certainly do encourage that. And certainly we invited some Somerset and Wakefield pharmacies that hadn't been to the training tonight before. And of course, if you can't get to the training, you can access that, and there is other online training which we'll cover in a moment. Okay, thank you, Sally. Jenny, you got anything to add to that? What Sally said?
I think Nicola's got her hand up. I think she might have something to share as well.
Okay, Nicola, we'll let you come in first then, and then Jenny can feed back after that.
Hiya. So we've done over 70 of these transactions now, and it's integrated really well into the needle exchange. Like Jenny says, it's a really quick transaction. We have one on the drawer, like right in front of us, to sort of wave at them, going, "Do you have one of these? Have you been offered?" The response is that nobody's been negative about it. So even ones that haven't wanted it for whatever reason, nobody's been aggressive or answered in an unpleasant way. They all seem to realise we're doing it to, benefit the client group and stop hearing sad stories about overdoses. And the whole team's been really behind it. So I feel that it's just been a really easy thing to integrate in with the needle exchange, to be fair.
That's great. Thanks, Nicola. Jenny, thoughts on those two?
I mean, just that's absolutely fantastic to hear. Really fantastic. And I think, that's what Nicola's just said about people get it, that you're trying to help them. And that people are aware that drug-related deaths are going up. They might not know the numbers, but increasingly they know of people who've died. They really do, and it's tragic. But to see an opportunity, they welcome it. And I had somebody in my clinic. I don't know if it's a good or a bad thing. Last Thursday she'd given it 6 times. And she said she's got a bit of a reputation now. People know that she knows what to do if somebody overdoses. So yeah, it's people are grateful for it.
Lovely, thank you. Any further comments from colleagues from Somerset or Wakefield? Lovely, thank you very much. Thanks, Sally and Nicola, for your input there. I think it's really vital to let people know that this has been launched in areas, it's been successful, and as I say, I mean, there's a different focus now in terms of moving away from a highly educational 2.5-hour face-to-face session giving you all the information to actually focusing on the real important effort supply, because if the Prenoxad is actually in the pharmacy, it's just doing no good there. So what I'm going to do, I'm just going to have a closing slide from me, and then we'll go to questions and then we will finish the evening. So some closing points. I want to just kind of give you a few contacts and also emphasise the next step. So Nikki Howe is the London rep in London for Prenoxad, and I've listed her email there. Now, Nikki's not on the call tonight. I didn't get a reply from Nikki, but I think that might have been because I forgot her off the list when I sent them out, because there were so many people that I had included. So apologies if that is the case, Nikki, because I'm sure she'll be watching this on YouTube very soon. What I'm going to do, I'm going to contact Nikki through Karen Bathgate, who is one of our organisers in the new service. And I'll get Nikki to send out dummy packs and client information leaflets. So as Jenny said, there's 2 types of information leaflet. There's the one in the pack, but clients generally won't access that until they use it, because we do recommend that the seal is left on until they actually use it. And the client information leaflet. We'll get Nikki to send you the packs. The packs are really useful. It's a tear-off leaflet. It's got information on Prenoxad, how to put it together and how to administer it. And on the other side, it's got how to respond to an overdose. So it's got about how you respond to it if someone's breathing and is not breathing. And that's the information that all the clients need. You can give them the information, you can show it to them, and then they can have a look at that. And most clients have a good understanding of how to use the needles anyway. We're going to get Nikki also to supply some window stickers. There's some great stickers that are being developed in Scotland around saving lives for naloxone. So we would really encourage you to use them in your windows along with the needle exchange stickers as well. So Nikki will be sending those to you as well. Karen Bathgate's been in touch with all pharmacies that had an expression of interest to deliver this and were deemed appropriate in the needs assessment. And she's asked you to return the contracts by the 16th of November. So if you could work on that and get the locally enhanced service agreements back by the 16th of November, that would be fantastic. The Neo 360 module, so there's going to be a naloxone module on Neo 360 for you to record these interventions. That will allow us to actually get an assessment of what is happening in terms of which clients are actually attending, who's been giving it out, and the reasons. But we're currently finalising that with Neo 360. The one thing that I will say with this, when we developed the farm outcomes one, we made it a lot shorter than other ones that we've developed. The whole point of this intervention and what we've tried to do is take this down from a long intervention using the consultation room where clients won't engage to, if you like, a very brief intervention. So it's not even a brief intervention, it's a very brief, often around 2 minutes. So the naloxone module will be the same as well. It will be a very minimal. So when can you start? When you've got the agreements in, when Neo 360 is up and running. Like I say, I'm speaking to them tomorrow, and they're usually very responsive. So I expect that the module will be up and running by the end of the week. When the dummy packs are at your pharmacy, you don't have to wait for the dummy packs if you don't want to, but it just might be useful for you to engage other staff, and especially with the training side of it. And when you have the client information leaflets, again, these client information leaflets can be downloaded from the Prenoxad website. And I'm just going to show you that in a moment. And when you have the Prenoxad in place and ready to supply, so you will order the Prenoxad from your local wholesaler, and you will claim for that on Neo 360 as well. I often get asked how many shall I order in? That's a decision for the pharmacy. I mean, we've had some really successful pharmacies that have really led from the front with this. If you want to touch base and touch the water and just see how you're going to get on with it, maybe you can order 3 in first of all, see how you get on with it, because the fact of the matter is you can get this in the next day, or you can get it in the afternoon for morning deliveries on most occasions. It's available through all the major wholesalers as well. So have a think about what you really want to do in terms of that. I've got a couple of other notes here that I just want to raise that I think came up from previous conversations. The stability of Prenoxad is very good. There's no temperature limits on it. There used to be a limit of 25 degrees centigrade, and we used to have to be careful how we stored it, but there's no temperature limit at all on it now. So clients can carry it around. They can carry it around in the summer. They can leave it in their car. Obviously, it gets very, very hot in the car, and we want to kind of have some practical approaches to it. But there is no temperature limits, and they don't need to keep it in the fridge. Occasionally, still we get some clients, or certainly when I was in practice, who keep methadone in the fridge and things like that. So it doesn't need to be kept in the fridge. It is quite a stable drug, so you need to be considerate of that. And what I would say to you, I'm hoping that we're in the position where the majority of you can start next week, where the naloxone is up and running, you've ordered the stock in, you've reflected on the training, you've maybe gone on to complete the SMMGP training, or training through Exchange Supplies. There's a very good module through Exchange Supplies as well. We mentioned the SMMGP training, but there's that module as well. And it's not a mandatory training. We've not made it mandatory because during COVID, all we wanted to emphasize was the supply and getting naloxone out. However, we would encourage you to use it. We'd encourage your staff to engage with it as well. And what I want you to think about is the next week, think about how you're going to manage this with your staff. How are you going to train them? Are you going to train them? Are you going to let them look at the dummy packs? Are you going to just refer them to this YouTube video so that they can watch this? But as Jenny said, there's an important need here for your staff to be able to deliver this intervention as well. If you think about it in the same terms of needle exchange, the majority of needle exchange in the pharmacies, and you think about the pharmacies are responsible for about 70-75% of needle exchanges, and so we're hitting that cohort, and the majority of those exchanges will be done not by the pharmacist but by your staff. So it's an element, it's a really important element to think about how your pharmacy staff are actually going to deliver that and how you're going to engage them in that process. So think about that. We'll let you know when the naloxone module is up and running, and Neo will let you know as well through their messaging system. I'd like to thank you for all engaging with this tonight. This has been a really well attended session. It's the first session I think we've managed to get the hardware and the software to work, and all the video and sound has been working. So it's great that this will be on YouTube. So hello, YouTube people. And thank you very much, and thank you to John at the LPC for supporting us and allowing us to run this within your service. So I'm just going to stop, or I'm not going to stop sharing the screen. I'm just going to bring this back up now. I'm just going to go to the comments. And look at that, Jenny. No questions. We've fulfilled everybody's needs. See, everybody.
Oh, there might be one.
Oh, right there. Okay, so okay then. There's nothing in the comments, and I'm mindful we've got a lot of people on the call. But if you have any final questions before we go, please put your hand up now. It looks like I'm going to get a hot chocolate.
Done a good job, guys. Thanks, Jenny.
I'm going to get a hot chocolate in before Bake Off, aren't I?
Yeah.
So that's tremendous. Lovely. Well, thank you very much. As I say, you know where me and Jenny are. We've got our emails on the presentation. I'll send the presentation to you tomorrow, John, so that you've got a copy of that and you can put that on the website. And we'll also, if you wish to, it's not my decision, and we'll let you know when the YouTube video is up, and we'll send the code out to that so that you can access that. And we look forward to the streets of City and Hackney being flooded with naloxone.
I'm sure it'll be trending on YouTube soon.
Exactly.
And I think it is important to say, isn't it, Graham, that after the Somerset launch and Wakefield, we were open to questions, and we did get asked a couple of questions. So, you know, if you're not sure or something doesn't sound right, or you just want to check, just get in touch and we'll answer that. That's absolutely fine. That's what we're here for.
Lovely. Thank you very much. So I'm now going to stop recording. So